Hey everyone, how's it going today? Let me know if you can hear or see me. All right, thank you, Abby. Appreciate it. Good morning. Good morning, Erica. I forgot to change the due date on your homework assignment. There's Savannah. We'll get started here in a minute or two. If you have any questions, feel free to pop them on up. All right, so it's just about 8 o'clock, so we can go ahead and get started here. Got about 9 people in now, so hopefully we'll get a few more people rolling in. So someone had a question. I updated the homework assignment, the due date. I went ahead and made it the 23rd by 6 p.m. So I can check that out. Forgot to update that this week, but that should be all good. Someone had a question. They said, when you say nitrosoureas also have the same effects as mustards, does that include the acrolein metabolite and CNS toxicity? That's not the case. That is unique to cyclophosphamide and ifosfamide. So those are unique to those drugs. You don't see that with anything else really. So important distinction to keep that on its own. So always remember, if you see something unique to a particular drug, like those are generally good things to key in on because they are fertile ground for test questions. All right, I think this is where we were in terms of our material from last week. If not, you can correct me. Things set up here so I can see a little better. All right, so we're talking about our surgery drugs, talking about our anesthetics, or sort of general anesthetics and whatnot, some sedative medications here. And I wanted to talk about our local anesthetics real briefly. Basically, instead of giving a drug that's kind of working from the CNS down and cause sedation or analgesia, we're going to look at ways we can try to prevent those painful signals from being sent up in the first place. And that's where our local anesthetics work. So they anesthetize locally. That kind of makes sense. So basically what we can see is that, nociception, that pain awareness, can be mediated through several places. So like our opioids are working more so like in the spinal column to blunt that sort of transmission of the signal up. Other sedatives are working kind of more in the CNS. But we will find that, local anesthetics can help to prevent the need for a lot of those medications by working locally to blunt that signal. So if you never feel like you're in pain, then you never need medications to treat that pain necessarily. which can be beneficial. And so basically what we can do is use these local anesthetics to reverse that impulse conduction. So we're going to find, when we look at the mechanism, they help to inhibit that action potential that would normally send up a pain signal saying, hey, this hurts, get away from it, or whatever your instinct is. This is good because you can use it very specifically. So if I have something like a knee replacement, I only have pain in the knee, I can just put the medication right there. The rest of the body is relatively spared. Interestingly enough, our first local anesthetic we ever discovered was cocaine from South America. That's why a lot of times if you see TV shows where they're testing to see if something is really cocaine or not, they'll rub it on their gums. Because if their gums go numb, then they have a good idea that it's cocaine. So because cocaine has some of those properties, which is nice. We're also going to see that a lot of the toxic effects of these anesthetics are going to be extensions of their therapeutic effects. So by blocking action potential conduction, that can affect things like the heart and the CNS. And so we'll look at some ways we can manage that going forward here. Basically, they work by blocking sodium channels. So if you look at a normal action potential for a neuron, you'll see that when you have the initial depolarization, that uptick in terms of electric potential is caused by sodium influx into the cell. Our local anesthetics are going to block that sodium and prevent that action potential from that positivity from ever occurring. Thus, you interrupt the signal, which is why you get that numbness, right? Because none of those signals are making up to the CNS. And so that's basically the mechanism of how we're going to block that further propagation of the signal here. There are plenty of local anesthetics that are out there. Here are some of the more common ones you may hear about or run into. Certainly cocaine you run into on more of an illicit substance sort of basis here. Plenty of your patients may have used cocaine at some point in their life or currently. We still use it occasionally as a medicinal product. It is considered a controlled substance. It's a C2. And so we may sometimes use it for certain types of surgeries. But other more common ones include things like prilocaine, mepivacaine, ropivacaine, bupivacaine, and then lidocaine. So again, if you see cane on the end, you can be pretty well assured that it's going to be a local anesthetic. Lidocaine is probably the most commonly one used. You may see bupivacaine, ropivacaine, more so if you're like in the OR type of setting there, but these are very common. We're going to see that their absorption can be dependent on several factors. So things like, how much, and again, I'm talking about like systemic absorption from the local site can be affected by things like how much we're giving, the site where we're injecting it, things like the lipophilicity of the drug, if we're using vasoconstrictors along with this. So a lot of times you're going to see lidocaine plus epinephrine. That's important in terms of a mixture because that epinephrine's acting as a vasoconstrictor. So we kind of get some of the benefits of cocaine because cocaine's also a vasoconstrictor. We can do that similarly with lidocaine plus epinephrine. So we'll look at some of the things to think about when we're using that there. So the vasoconstrictors help to do a couple of things. So one, they prevent systemic absorption of the local anesthetic because they're constricting those blood vessels so you don't absorb as much. That means I can use a higher dose than normal. So as an example, if I were to say someone had a laceration that you needed to suture up and you wanted to numb the area, well, normally if you're just using lidocaine by itself, you may have a max dose of say like 5 milligrams per kilogram. If I'm using lidocaine plus epinephrine to constrict all those little vessels, I may be able to use up to 7 milligrams per kilogram because less of it is going to get absorbed systemically, and that way I don't have to worry so much about the toxicities. That can be a benefit. Other things you're going to see too is that the vasoconstricting actions also lead to less bleeding, so that can be useful if you're trying to suture up a laceration and you have less blood in the way. You can kind of get a better view and can kind of do your work a little bit more easily there. So that can be beneficial from that standpoint. As I mentioned, epinephrine is going to be the most common one you're going to see as a vasoconstrictor used in combo these local anesthetics. So you can see things like ropivacaine mixed with epi, bupivacaine mixed with epi, but lidocaine plus epi is probably the most common one you're going to see there. Note, though, that you don't want to use vasoconstrictors in areas of terminal blood flow because you can see decrease in delivery of oxygenated blood to the tissue, and that can cause obviously tissue damage, tissue necrosis, nerve damage. So there's a handy mnemonic to remember where not to inject a vasoconstrictor. That's the fingers, toes, penis, and nose. perhaps a little crude, but it kind of gets the point. So anywhere we're having terminal blood flow, so the fingers and toes, you don't want to be injecting epinephrine into those areas, because again, you can see them getting very white, blanched, because they're just not getting as much blood as they really need there. So it's one thing to consider. Plenty of ways we can administer this. So for instance, topically, we can use things like topical lidocaine. There's transdermal lidocaine used for things like neuropathic pain we've talked about previously. Most often you're going to be using these as injection. So either using them locally, for instance, like at the site of a total knee replacement. We'll use these a lot in, for instance, if someone is pregnant going into labor, we can use this for their epidural in order to get sort of a local sort of anesthesia to certain regions of the body. So for instance, when someone's giving birth vaginally, their pain is very much localized to their lower half. So we can give medications in the spinal column that way only affects the nerves for that lower half of the body, which can be very beneficial from a pain sort of standpoint. So how do we pick which ones we're going to use? Well, some of it can be very dependent on sort of what your purposes are, right? So for instance, if I have someone who comes in with, say, eye pain to the ER, and maybe they had a history of dust blowing in their eye or something, and you need to do a fluorescein stain, you need to do lid aversion, and you need to numb up the area so that we can get all those things done, so you can get a good ophthalmic exam. You don't really need that to be a really long-acting medication there, because you're doing a pretty quick procedure. So something like Procaine might be a good option there. So that's kind of your short-acting sort of anesthetics. If you don't need something to be acting, maybe a little bit longer. So for instance, for the duration of, say, a procedure like a laceration, dental procedures, things like that, we can use things like lidocaine, bupivacaine. And then we also have long-acting formulations that are good if you needed that area to stay numb for a while from like an analgesic sort of standpoint. So for instance, if we are going to send a patient home after a total knee replacement, for instance, and we're using a local nerve block there to prevent pain, we may use a long-acting medication like bupivacaine or ropivacaine in order to get nice sustained numbness of that area, so that way the patient's not experiencing much pain, and that way they don't need to use as many drugs like opioids, for instance. So a lot of these tend to be opioid sparing, which is very beneficial from that standpoint. So in terms of toxicity, we're going to see here this is most often either due to inadvertent administration of this stuff IV, which lidocaine we use as an antiarrhythmic IV, so that would be one of the few instances where you'd see an IV local anesthetic. But other drugs you're going to see here, if they are accidentally either given IV or they're absorbed from their local site of administration, that's where we can start to see some of the systemic toxicities here. And so basically what we're going to see, the main problems is going to be neurotoxicity, and then cardiac toxicity are going to be the main problems here. Okay. From the CNS standpoint, you can start to see things like they get maybe a little bit sleepy, they're starting to get some lightheadedness. Honestly, one of the big things you're going to see that could be indicative of more CNS toxicity from the local anesthetics include things like tongue numbness. They may complain of sort of metallic taste in the mouth. That's usually not a good sign. And then that can lead all the way up to things like fasciculations of the muscles. You can see seizures develop here. So it can be certainly on a spectrum. But you want to notice those early signs if at all possible to see, okay, we're going the wrong direction. Maybe we should stop giving any more of the medication there. Otherwise, and you'll see this a lot more so with like the lipophilic anesthetics, like bupivacaine is particularly notable for this. Here you can see from a cardiovascular standpoint, they can block all the sodium channels in the heart, leading to things like broad complex arrhythmias. You can see things like ventricular arrhythmias that can develop here, and so that is a big concern when using things like bupivacaine, and then you're absorbing too much of it systemically. You can see that severe hypotension and arrhythmia come along with that. We can actually treat this. So there's an antidote to this, and it's actually giving a drug called intralipid. And so if you've ever seen someone who is on total parenteral nutrition, or TPN, that's a way that we can give someone all of their nutritional needs through an IV instead of needing to take anything orally. And to provide that fat component, we use something called intralipid, which has all of basically the fat molecules that you need for a given day here. Because something like bupivacaine is really lipophilic, we can actually give intralipid IV, and it sort of forms what they call a lipid sink. So it sort of sucks all that bupivacaine off of the heart into this fat layer in the blood now, and allows your body to metabolize it off. So it's kind of an interesting, sort of unique little antidote to that. And that could be used for, if I have someone who's going into an arrhythmia from any local anesthetic, this would certainly be the first thing that I'd reach for. Another thing that is sort of particularly unique to benzocaine in particular is it can cause something called methemoglobinemia. If you've ever seen this, this is basically where you cause your patient to turn blue. They get cyanotic, and this is not necessarily related to their inability to breathe. Normally, if you see a cyanotic patient, you are quite concerned about their respiratory system, but this is something to where strong oxidizers like benzocaine can actually convert hemoglobin over into methemoglobin. And when that happens, it has to do with the iron in hemoglobin being converted over to from a 2+ to a 3+ state. And that basically causes the patient, or the blood, to, instead of binding oxygen, likes to bind water. That gives it the dark color. And so sometimes they'll have like a chocolate colored blood. You can Google pictures of this and see what it looks like. But this is typically seen with benzocaine. We use benzocaine a lot in something called hurricane spray or lidocaine spray. Basically, if you needed to give someone an NG tube and you wanted to prevent them from gagging and coughing and vomiting, you can actually numb up the back of the throat, because that's normally what activates their gag reflex. And so some people will use way too much of this stuff and they'll spray until the whole bottle's gone, basically. And this can actually lead to that methemoglobinemia. It's not great. Patient's blue. You're wondering what you can do for them, and you can actually treat this with something called methylene blue, which is a dye, which, surprise, surprise, is a very dark blue. So you have a blue patient, you give them a blue dye, and actually turns them back pink, basically, because it can convert that methemoglobin back to hemoglobin. So kind of an interesting way to manage that. So two big distinctions here between chemical classification of the anesthetics here. We're going to have our amides, and then we're going to have our esters. We're going to see here that this will be important because some patients may come up and complain about an allergy to one of these anesthetics here. And so you need to know that, okay, well, which ones are they likely to cross-react with? Which ones are they not? If they come up and they complain about an allergy to one of the amide anesthetics, they're likely to have an allergy to other amide anesthetics. And vice versa, on the ester side, they have an allergy to one of the ester anesthetics, and they're probably going to have a reaction to the other ones. But you can cross over, and that's totally fine. So if someone had a problem with lidocaine, they could switch over to use something like benzocaine, potentially. I'll show you that list here in just a second. How do you tell the difference of something as an amide versus an ester? Pretty easy. All you got to do is look before the cane in the drug name. If there's an I anywhere, then you know it's going to be an amide. So amide, I. If there's an I before the cane, it's an amide. So lidocaine, there's an I before the cane. Bupivacaine, there's an I before the cane, so on and so forth. So if they have an allergy to something like lidocaine, then they're more likely to have an allergy to something like bupivacaine. On the flip side, if you look at the esters, you can see here that there's no I before the cane. So if they said, okay, well, I have an allergy to lidocaine, then they can get something like procaine, no problem. Okay, very low cross-reactivity there. So that's something you can do potentially. Now, allergies are more common to the ester class. That's one thing you can note there. So generally speaking, your amides are going to be a little bit safer from that standpoint. And like I said, the cross-reactivity is quite low there from that standpoint, so you can switch classes, and that's totally okay. One of the problems you're going to see as well is that if the patient still has an allergy to the anesthetic, oftentimes it is not due to the actual drug itself, but it has to do with something that it's formulated with. And this may actually be related to multi-dose vials that have preservatives in them. And so if that's the case there, it's usually something called methylparaben that people tend to have more likely to be allergic to. And so with those cases there, you can use single dose vials, and that usually will get rid of all the preservatives, and then you can use that. That's pretty safe from that point there. Keep in mind, though, a lot of people don't know the difference between them. They just know they had a reaction to something with a cane on it. So Novocaine is a common brand name. They'll just say they don't really know what they got. So if you have previous records, that can be useful to see kind of what was really going on there. So that's it for that section. I'm going to go ahead and switch gears here. If you guys have any questions, feel free to post them up. It can be anything at all. I don't mind doing on tangents or just anything. Okay, so next up, we're going to be talking about HIV and some of our STI treatment here. So first off, we're going to start talking about HIV. We're going to go over the medications we're going to be using here mostly, and then covering some of the more things like opportunistic infections a little bit. Now, this category is going to be kind of tough because a lot of the drug names sound very similar, but it's important that you are able to distinguish between them, because one, you have to be able to tell like what makes up a good HIV drug regimen, and then also being able to categorize things based off of their mechanisms to be able to tell, okay, what drugs are more likely to cause which side effects and things like that. So again, a lot of these drugs are going to end in VIR, which means antiviral, but so you're going to make sure you kind of be able to recognize those, because again, most of the time your answer choices on your test are all the same. It's just 4 drug choices, so you have to be able to distinguish, okay, what category these fit into, and then based off that category, what are the side effects, what's the mechanism, et cetera, et cetera. So anyway, so HIV, it's a retrovirus, meaning that it's using our cells in order to make more copies of itself. It's kind of hijacking our cells' ability to be healthy and replicate on its own. There's 2 main varieties you're going to see, HIV 1 and 2, depending on where you end up working. You may find some are more predominant than others. So for instance, like HIV 2 is much more predominant in places like Africa than over here in the US. That'll be important for 1 or 2 drugs where you're going to see that they are maybe more likely to work for one versus the other. And so we certainly know transmission happens through either sexual contact, parenteral, maybe sharing IV or contaminate needles or something, perinatal transmission. And the big problem is that HIV itself is not necessarily, patients don't necessarily get all that symptomatic just from having the virus on board, because it's actually a long time period where people can be asymptomatic. The problem comes when they have kind of progressive destruction of the immune system, and they can develop what we consider to be AIDS, right? So the acquired immunodeficiency syndrome. So that immunodeficiency will be expressed by having a low CD4 count, and their increased susceptibility to opportunistic infections like PCP pneumonia or PJP pneumonia, as you're going to see more commonly now, toxoplasmosis, a whole host of things that if you have a competent immune system, you can be exposed to every day and have no problem. You can fight it off. These patients may not be able to. And so the mainstay of treatment is going to be pharmacotherapy, right? Not a whole lot of non-pharmacologic means of managing these patients. You need to utilize these highly active antiretroviral drugs, or heart therapy, as you may see them being termed as. So looking here, you can kind of see the life cycle of HIV, and it'll be important to kind of recognize these different steps and what's going on here, so that way you can see where the different drugs are working. And as you can see here, there are quite a few different drugs that are available that can potentially be used for these patients here. So that's why being able to distinguish between them based off of their mechanisms is going to be really important here, okay? So basically what you're going to see, here's the HIV molecule or particle itself. It's going to come in, it's going to have a fusion here with the actual cell membrane, so that way it can kind of come in, uncode itself, and then release its RNA. You're going to have the RNA polymerase, or the reverse transcriptase, kick in here to form viral DNA. And then we're going to have what we call an integration step, where basically the viral DNA is going to get incorporated into our DNA. And then that will allow for now our cells to start replicating that, to start to produce new proteins and whatnot. That will then cause translation to occur. We'll have the new viral proteins. And then we're going to have sort of maturation of those proteins. That's going to be through the protease enzyme. And then once you have those mature proteins, they can be bundled back up and then shed off into affect another cell, basically. Okay. Here's kind of more details on kind of what's happening there. But again, by understanding the life cycle, you can understand where the drugs are working, which is critical to being able to kind of piece all this together from sort of a conceptual standpoint. But yeah, so the HIV loves cells that produce CD4 receptors, which are some of those immune T cells we're talking about there. Some of them may actually also be looking for a receptor called CCR5. That'll be important for one drug class here. Once it's bound, you'll see the fusion step occurs, right? So it's able to fuse with our own cells. So if we can prevent that due to medications, that may be another step to prevent the virus from even getting in the first place. Once it uncoats, it'll have this single-stranded RNA, and then it'll use the RNA polymerase or reverse transcriptase to make a complementary strand of DNA. That's why it's a retrovirus, because it uses reverse transcriptase. The reason why HIV can be really tough to treat is because it is very error-prone. It's not, it's kind of very sloppy in its work, so it leads to a lot of mutations that occur here. And so we'll talk about drug resistance and whatnot, because this is absolutely critical for these patients as well. So then you're going to have a double-stranded form of DNA, and again, a lot of those mutations lead to things like the inability for the host to develop antibodies to fight it off, the inability to for certain drugs to work anymore because of mutations. And then once that DNA is formed, it can then get down to the nucleus and then get integrated via the enzyme integrase into our host DNA. So now our DNA is able to produce the new viral proteins. And then once those proteins are made and they're matured through the enzyme protease, then they can form a fully new functional molecule of HIV and then shed it off into the next cell. Okay, so then just kind of a wash, rinse, repeat thing until your immune system is completely obliterated, basically. So kind of three main phases. You can have the acute sort of infection that occurs here, which you may have sort of an inflammatory response to, sort of the acute retroviral syndrome. Some people may be asymptomatic though, or they just may think it's a cold or something they experience. And they'll go into a latent period, which can last from months to years potentially. And it may be quite a while until they actually get diagnosed if they're not being checked regularly. Which most patients aren't, but some that are that practice high risk behaviors may be more likely to be checked. But sometimes the first time you actually get the diagnosis is when they come in with one of these kind of terminal AIDS defining illnesses. Someone comes in and they have active TB, for instance, and maybe something that's on your differential. They come in, they have thrush, or they have PJP pneumonia, or something like that. It really should kind of clue you in that, hey, something's going on in their immune system here. This is on my differential. And when we're monitoring these patients, kind of the two big things we're going to be looking at is going to be the viral load, which tells me how active the virus is in replicating, and then the CD4 cell count. And this is going to be telling me how extensive is the immune system destruction, or how well has it recovered. So we want HIV viral loads to be undetectable, and we'd like our CD4 count to be high. So our goals here, increase quality of life, increase quantity of life, hopefully preserve immune function as much as possible, and try to prevent transmission to other people if at all possible as well. So we've got some ways we can do that. Here we're going to see that, I feel like I have a sneeze coming on. Excuse me, I didn't want to do that into your ears, so hopefully. Sometimes I'll feel like I have a sneeze coming on, it takes me like 30 seconds and then it goes away, and it's just kind of annoying. But anyway, and what we're going to see here is, HIV was really first coming onto the scene back in the 80s. Back then we didn't have any medications for it, so it was something to where it was kind of a death sentence for a lot of these patients here. But nowadays they're able to live long, full lives, and now they're starting to die off from things like heart disease and diabetes and all the stuff that we normally die off of as well. And so we're going to look at some of the drugs that maybe can exacerbate that, and some of the things we can look at. Oh, thank you so much. The first person I think has ever blessed me for sneezing on the stream, so that's very nice of you. But anyway, so yeah, that's what we're going to be looking at in terms of medication management here. So as I said, as you have continual replication of the virus as it continues to hijack more and more cells, that's where we're going to get that eventual immune system destruction, to where we can have an AIDS-defining illness occur here. And so if we can get the RNA levels down as low as possible, that viral load that's undetectable, it's a good sign. And then we're going to be looking at our CD4 count to keep those high. So we use the HART regimens, the highly active antiretroviral therapy, in order to try to get those undetectable RNA levels by causing kind of selective pressure against them. And then we're going to see that we need multiple agents. So patients may be on a minimum of 3 drugs. There's actually a few newer regimens which may be recommended for just 2 drugs, which is, within the past year or so it's been recommended. But for the most part, 3 or more drugs are needed here. And then we're going to be doing resistance testing as well to see, okay, well, is this regimen we're using effective? Do we need to try something else? And just keep in mind that, once you have resistance to one set of drugs, it may be difficult to find alternatives. So you want to make sure that compliance is maintained as much as possible here, because non-compliance leads to resistance, which leads to not having a whole lot of options going forward. Because again, you got to treat these patients the rest of their lives potentially, so you don't want to be losing options here due to non-compliance early. So we'll talk about some other factors that go into that. Back in the day, we didn't really have a good idea of like when to start treating patients, and we used to hold off on using treatment until their CD4 count got to like 200 or 100 or 50, because we thought, okay, well, we want to save our drugs for as long as possible, but we realize now that there's a lot worse outcomes when you do that. So now the second you find that someone has HIV in their blood, you go ahead and just start treating them. This helps to do things like reducing transmission to other people. It also helps to reduce the number of age-related events that occur here. So basically, once you got the diagnosis, I don't care what your CD4 count is, could be 400, could be 2, you go ahead and get treatment regardless. So here are the main classes that we're going to run into. We have our integrase inhibitors. We're going to have our nucleoside or nucleotide reverse transcriptase inhibitors, so NRTIs is how they're most often referred to. We have our non-nucleoside reverse transcriptase inhibitors, NNRTIs. You can see how this is starting to get confusing. We'll have our protease inhibitors. We'll have our entry or fusion inhibitors, and then co-receptor inhibitors. These are the main classes we're going to be running into. The top 4 here are going to be sort of the backbones for the most of your regimens, as we'll see here in just a little bit. So the NRTIs are the first class we're going to be looking at. This is, again, going to form the primary backbone for most regimens. So most patients will be on at least some of these. You're going to see that the other ones may be sort of optional depending on the kind of the regimen you're going with. But I'll show you some examples of that. Just like we saw with oncology, there was a lot of use of acronyms. You're going to see the same thing here. I'm not going to ask you about acronyms on the exam. I'm just listing them just so kind of have some familiarity with it if you ever see, maybe run into this on rotations or something. And I don't care if you know if it's a thymidine analog versus a deoxycytidine. I'm not going to get that granular with it. At least be able to recognize, okay, which one of these fall into the NRTI category. So we have stavudine, zidovudine, we have emtricitabine, lamivudine, abacavir, didanosine, and then tenofovir. These are the most common ones you're going to be running into out there. And what do these do? Well, basically, if you're looking at the reverse transcriptase enzyme, there's a couple ways that we can try to interfere with this. And so it's good that we've recently talked about oncology, because this is going to be sort of similar or analogous to some of the antimetabolites that we looked at before. So basically, just like your cancerous cells are using DNA polymerase to make new cancerous DNA, we can see the reverse transcriptase here is being utilized to make viral DNA that can eventually be incorporated into our DNA. So if you can inhibit this process by introducing a chain terminator where it can't add on any more nucleotides to it, then you can't produce any more DNA. So this is how we're going to be doing this, is with the NRTIs. They're basically going to put a stopper here on the end of the DNA, unless you can't get any further elongation. So kind of think about this as analogous to something like cytarabine, for instance, right? Acting as a chain terminator, can't produce any more DNA or add on to any more DNA there, thus you prevent replication, okay? We're going to see that a lot of the, it'd be nice if these were perfectly specific for our HIV, enzymes, our DNA, but we're going to see there is going to be some cross-reactivity. So for instance, here we can see things like mitochondrial RNA and DNA synthesis being inhibited to some degree. This can lead to things like, some lactic acidosis that can occur here. We're going to see that this is more pronounced with some of the older agents, things like stavudine, didanosine, and zidovudine. Some of the newer agents are going to be more preferable in terms of side effects. You're going to see a lot more regimens, including things like abacavir, tenofovir, emtricitabine, and lamivudine. I'll show you some example regimens a little bit later on here. Other problems they can run into include things like peripheral neuropathies, pancreatitis. You can see things like myopathies that can occur here. And again, these patients may be on these drugs for decades, so these are things you want to be monitoring for over that period of time. Abacavir is unique because it actually has some genetic testing you have to do before you place a patient on it. It is for this polymorphism that people can have. It's called HLA-B5701. Probably not as important to memorize that string of numbers and letters as it is to know that you have to do this genetic testing for a Abacavir specifically, because if you have this, then you are more likely to have a hypersensitivity and have anaphylaxis due to Abacavir. Okay, so if a patient had this, then you do not want to give them Abacavir. If they don't have it, then you're okay to go. Okay, so that's why we would test for this prior to giving it, because you don't want to accidentally give someone anaphylaxis when it's common enough that you need to test for it. So the next class here is the NNRTIs, and so this is going to work on the RNA polymerase as well, the reverse transcriptase, but instead what we're going to be using here is a drug that does not do anything to the actual chain of DNA that's being formed here, but what we're going to use here is actually a drug that can change the conformation of the RNA or the reverse transcriptase, and that then prevents further development of DNA. Okay, so it wants to come in here and get replicated with the reverse transcriptase, but it can't add on anymore, or it can't do anything with it. So basically, by using these two together, they can work synergistically to help prevent reverse transcriptase from ever producing that DNA in the first place. Okay, that's kind of how that's working there. We have delaverdine, efavirenz, nevirapine, etravirine, or ropivirine. Some people say efavirenz. I say efavirenz. It doesn't really matter. Here you're going to see things like rash, transaminitis, so you definitely have to monitor for liver function. Here is going to be important. This is an okay class, but you're going to see it's not going to be one of the first line preferred ones, mainly because of the fact that resistance is a problem. You're going to see here that for a lot of these, except for etravirine, if you have a mutation to, and all of a sudden you're resistant to efavirenz, now you can't receive any of the other drugs because you're going to be resistant to all of them except for etravirine for the most part. Not great because once you lose this class to just one drug, you lose the whole thing, which is not great. Then next up we have our protease inhibitors. These basically, once you have your cell has produced the new proteins because you've now had the integration of that viral DNA into your DNA. Basically, it's going to translate this big long string of proteins, but that's not mature yet. That has to be kind of chopped up into their constituent components, and that's done via the enzyme protease. And if you can prevent that from occurring, then you can't make a whole new, DNA or HIV organism, right? You can't produce a whole new one because it's going to be stuck in this sort of pre-made sort of or immature sort of state in terms of its proteins. So this is going to include atazanavir, darunavir, fosamprenavir, indinavir, lopinavir, which oftentimes comes in combination with another protease inhibitor, which will be important. I'll talk about in a moment here, called ritonavir, of nelfinavir, ritonavir by itself, sequinavir, and then tipranavir. So quite a bit out of this category here. So this one, you're going to see a lot of metabolic effects associated with it. So things like increased lipids, glucose intolerance. And again, these patients may be on it 20, 30 years. So now we have to think about things like heart disease and diabetes and all of that. Kind of unique side effect as well with the protease inhibitors is this altered fat distribution or lipodystrophy. And so you can kind of see this characteristic buffalo hump, they call it, that can occur with these patients here if they're on it for quite a long period of time. So obviously probably a bit distressing to the patient, I would imagine. So most of these get metabolized to the liver. There's going to be a ton of different CYP interactions here, some of which we can actually harness for our own benefit. So for instance, there's two medications here, ritonavir, which itself is a protease inhibitor, and then another drug called cobikistat. And we can use them because they are strong 3A4 inhibitors. And you're probably thinking, well, wait a second, that sounds like a drug interaction. We don't want to do that. That's actually good in these cases here because we can use it to boost levels of other medications. So for that example I showed you, it was lopinavir. It's boosted through the use of ritonavir. So you have higher levels of the drug, so you have to give it less frequent. That means you can basically have better compliance because you're taking pills less often. It just makes the regimens easier to be compliant with. However, it's going to affect all the other medications you put them on, so you have to be really watchful for that to make sure you're not going to cause any major drug interactions there, like simvastatin plus ritonavir. That's a recipe for liver dysfunction and rhabdo, right? So you got to be really careful with those. So ritonavir and cobikistat are the two major 3A4 inhibitors we're going to be looking at here. Next, we can try to use something that prevents the fusion of the HIV virus from even getting into our cells in the first place. And so this is enfuvirtide or Fusion. This one is specific to working for HIV-1. So if your patient had HIV-2, this would be ineffective for them. Again, another reason why you're not going to see this used as like a first-line drug here, but it could be a useful add-on if they did have HIV-1. This itself is a protein, so it is going to be an injectable product. So again, not great from a compliance standpoint from that. And you can see things like pain, erythema that can happen here. Good aseptic technique is really important because they may have a poor immune system, so you don't want to get them to get secondary skin infections. So not great from that standpoint. So it could be a useful add-on, but it's not going to be one of your first-line drugs here. And then you have your CCR5 antagonist, one drug in this category as well called Maraviroc or Cellzentry. This one does work on HIV-1 or 2, and interestingly enough, this doesn't work on any of the viral sort of targets here. It actually works on the human receptor that your CD4 cells may be expressing. However, not every HIV virus is looking for this. Sometimes they can mutate, and then all of a sudden they're not looking for that CCR5 protein. So you have to check the strain of the virus to see if they are even looking for that. And if they're not, then this drug is not going to be good for them. Overall, well tolerated, but again, monitor for liver function is going to be the big thing here. The final big class that we're going to see, and this is becoming sort of first line in a lot of regimens, is the integrase inhibitor. So this prevents the viral DNA from being integrated into your DNA. So that's a critical step there in order for the new viral proteins to be eventually translated into and be to be made. So we have raltegravir, dolutegravir, elvitegravir, and then bictegravir. Some of these you may see co-formulated with things like cobicistat. So for instance, elvitegravir can be utilizing that cobicistat for the 3A4 boost, basically. And then a lot of these you're going to see in combo products in order to help with compliance. I mean, if you look at regimens that patients with HIV used to be on back in the 90s, they'd be taking dozens of pills a day, basically, just to keep that virus at bay. Nowadays, we have a lot of options where it's just one pill a day. So it's really awesome from a quality of life standpoint. The patients are not, having to think about how many times they have to take their medication every day. It's just a one and done sort of thing, which is fantastic. But basically, these bind to that integrase enzyme and prevent the viral DNA from getting incorporated into ours. Okay. Here we're going to see the side effect profile is also really nice and pleasant compared to a lot of other ones. So maybe some rash, nausea, headache. Very, very much preferred over a lot of the other ones. Not as many metabolic effects as the protease inhibitors. Not as much hepatotoxicity as in NRTIs. Things like that. So very, very nice from that standpoint. Now, as I mentioned with drug interactions, sometimes these are on purpose in the case of things like ritonavir. However, some of these may be inducing 3A4. So for instance, like efavirenz, etravirine, nevirapine can induce 3A4 to lower levels of other drugs. Okay, most protease inhibitors are going to be inhibiting 3A4, so it can boost levels of other drugs that are affected here. And that can be important. For instance, if a patient who has HIV may also have TB, and if they're on drugs like rifampin, rifampin's an inducer. So if they're taking something that is metabolized through CYP3A4, and then now you start to induce 3A4, you can lower levels of that, and that can lead to more HIV resistance. Not great. Some of them have specific food-drug interactions, so some of them need to be taken on empty stomach, some with fatty meals. So again, look this stuff up. I took a whole elective on this, a whole semester-long elective on this in pharmacy school. People go into fellowships just to do this, so there's a whole lot here. So this is really just sort of the brief overview. So this is not everything, but when in doubt, look it up, because even though you may not be the one prescribing these medications here, you may have patients who have HIV that you're dealing with that you need to consider, okay, well, what kind of drug interactions am I going to see here? Because if you're in the ER, they come in, you give them medications, and they happen to be HIV positive and have these medications on board, you can't just say, well, I don't deal with HIV. I don't know what to do with these medications here. You got to look it up. You got to find it out, right? So treatment here is always evolving, right? Just like the virus is evolving, you're going to see here that this is always evolving. And so new recommendations are always available. And this is actually, I need to update this. It used to be AIDS info. I think you can still find it if you do that. It'll redirect, but now it's hivinfo.nih.gov. And this is a really great resource both for patients and for yourselves in order to get guidelines that are up to date and all of that. Basically, though, most regimens, again, there's a few that are 2-drug regimens nowadays. But that's relatively new. There's majority of them are going to be 3-drug regimens here, usually including a backbone of 2 NRTIs, plus a drug from a different class. So the main ones they recommend nowadays include an integrase inhibitor plus 2 NRTIs, So for instance, raltegravir, tenofovir, and emtricitabine. Another regimen you could do could be a protease inhibitor plus 2 NRTIs. So here's an example of darunavir getting boosted by ritonavir. So it's now a 4-drug regimen plus tenofovir, emtricitabine. Or, which is less preferred, you could do an NNRTI plus 2 NRTIs. So favirenz, tenofovir, emtricitabine. So I will tell you right now, there's going to be a test question. And it's going to say which one of these is an acceptable HIV regimen for your patient. And I'm going to have one that might have like 4 protease inhibitors. That doesn't make sense because it's not what we said here. It might have 3 NRTIs. We can't really do that. You have to use something, that third drug has to be something out of a different category. The challenge, though, is you being able to recognize which category these drugs fit into. So you got to know which ones are protease inhibitors, which one are NRTIs, NNRTIs, etc. So I'm telling you now, there's going to be a test question like that. So no reason you shouldn't be prepared for it. So if you have if you have troubles getting and linking drugs back to their individual classes, I suggest getting flashcards and just having quick associations on this card. Just have darunavir, protease inhibitor, on the front and back. Just make that quick association. That's going to be a big help to you guys, I think. All right. So adherence is variable adherence is pretty common here, and this is critical because you're going to see this can lead to a lot of variability in terms of the success of the drug regimen here. And reasons why people might have poor compliance include things like concomitant psychiatric illness, schizophrenia, bipolar disorder, concomitant substance abuse disorders like IV drug abuse, opioid abuse, cocaine abuse, adverse effects seen from the medications that may lead them to not want to take it anymore, and then unstable social circumstances like, maybe they don't have a home, maybe they have, not easy access to getting these medications here. There's a lot of programs out there to help people, but again, it takes a lot of work. So things like social work can be really critical to helping these patients become successful. So a lot of challenges here, depending on your patient's individual circumstances there to consider. If possible, always use combo drugs to help limit the pill burden these patients are having to experience. So that way they can take 1 pill a day. That's awesome. That would be fantastic. However, just be careful with things like food restrictions and whatnot, depending on the medications they're receiving there. And some examples here include things like a favirenz, emtricitabine, tenofovir, a tripla. Some of these including integrase inhibitors, emtricitabine, ropivirine, tenofovir. A lot of different options you have available to you. So just some examples. I'm not going to ask you specifically which ones of these are available, but just so you know that, hey, those options are available to some of your patients. So when it comes to resistance testing, you're going to be doing this too, along with a patient with a new diagnosis. And you're going to see that there are 2 types of testing. There's genotypic testing and phenotypic testing. Genotypic testing is going to be the more limited one, and basically it's going to take that virus and it's going to sequence it, figure out what is its particular genome, right? What that's going to do then is they can then take that genome, compare it to a database of known mutations to see, okay, where am I seeing these mutations at? And that says, okay, well, based off this mutation, I would expect it to be resistant to this drug. I can't use that drug anymore, okay? I would expect it to be resistant to this drug. Okay. The problem, though, is that it gets very complicated when you're in vivo and these different mutations may be interacting with one another, and that's not going to really come up on that genotypic testing. But it's quick and easy to do, and so you may do that as kind of an initial step for most patients. Phenotypic testing is much more similar to what we would do if we were trying to culture and get a sensitivity on a bacteria. You could actually culture it out. You can then expose it to medications and actually tell, okay, which one specifically, based on this particular virus, which drugs are sensitive or resistant to it. Okay, it's slower, has more cost, but can provide you more info on those complex mutation patterns. So it may be done, especially if you have patients who are coming back and they've been compliant to their regimens, but their CD4 count's still low, viral count's still high. This can give you some more information there. So those are the 2 types of testing. Genotypic is easier, but less info. Phenotypic takes longer, more expensive, but gives you much more concrete info in terms of what this virus is particularly resistant to. So just in terms of some special populations here, in pregnancy, you're generally going to find that most pregnant patients will be treated as if they were not pregnant because we see that if we have chronic suppression of the virus in the mom. This helps to limit the exposure to the fetus, which is great. We don't use the efavirenz though, because that can cause neural tube defects. That'd be one thing that's very teratogenic we would avoid. And then hopefully the mom is suppressed throughout the pregnancy. Then once the baby is born, then we could provide zidovudine for about 4 to 6 weeks for that infant. And that helps to prevent any virus they may have picked up, like for instance in the birth canal, and prevent them from having an established HIV infection. Breastfeeding probably avoid, especially when they're taking medications, just to make sure the baby's not getting exposed to anything unnecessarily. In some cases, we may do what we call pre-exposure prophylaxis or post-exposure prophylaxis. So post-exposure prophylaxis would be something for like healthcare workers, for instance. Let's say you are doing suturing up a patient with HIV and you accidentally stick yourself with a needle. Or your, I'm trying to think of it, your sutures. Not great, right? So what can you do? Well, one, obviously wash off the area with soap and water. You want to start therapy as early as possible. Ideally, if you know if your patient has it, that's always great to know whether or not they're yes or no. But sometimes you may not have the patient available to you, or they may not know what their HIV status is. In those cases there, we go ahead and just do a full court press for a month, generally with an integrase inhibitor plus 2 NRTIs, like raltegravir, emtricitabine, tenofovir for 4 weeks. That is usually managed through either like the employee health department or most places where you may have accidental needle sticks. They'll have some sort of program in place to make sure that workers can get their access to the medications cheap to free in a lot of situations there. Now, pre-exposure prophylaxis can be done for high-risk individuals who are currently seronegative to prevent them from picking up the virus in the first place. So you may see this in patients who have high-risk behaviors. So for instance, like IV drug abusers, patients who may not be using protection in their sexual encounters, serodiscordant couples. So for instance, one partner has it, the other doesn't. One of the other things too is that men who have sex with men, receptive anal intercourse is the most likely transmissible way to get HIV. So again, that population tends to be a little bit higher in terms of contracting the virus than others potentially. So these are people you may consider to go ahead and give them pre-exposure prophylaxis to prevent them from getting the infection in the first place. In that case there, obviously good education on things like using proper protection and trying to prevent them from using IV drugs is always great. But here we can use things like daily tenofovir and emtricitabine, and that will help to make sure if they do get exposed to any virus, that it does not get a foothold and cause an infection. It's important to make sure they are seronegative prior to initiation, because if they are positive, then you got to give them the full treatment anyway. In terms of evaluation of outcomes here, we're going to see that we're looking at CD4 and viral load. Again, we're going to be doing resistance testing as well at first to make sure that they have not picked up something that is particularly resistant, and then we'll monitor every 3 months until the RNA is undetectable. Reasons why we might want to change the regimen include if they have intolerable side effects, that just like it's too miserable for them, they only want to have it on board. If they have treatment failures, so the RNA is still high even after they've been on for several months, or if they have documented resistance, so that genotypic testing comes back and says, hey, you put them on raltegravir, but this mutation says it's going to be resistant, switch them over to something else. So let's look at a few complications of HIV and AIDS. These are typically opportunistic infections that can occur. And we see that pretty predictably, as you get down to certain CD4 levels, you are more susceptible to certain types of opportunistic infections. This can range from anything like oral candidiasis or thrush all the way down to life-threatening cytomegalovirus, Mycobacterium avium complex, PJP pneumonias, all kinds of things. And again, these are kind of what you consider to be your AIDS-defining illnesses. So you may have HIV for a while, you get one of these, then you're considered to have AIDS at that point. And again, these are things that we get exposed to all the time, but we have competent immune systems that can fight off. However, these patients may not have that ability to, and that's why they're more susceptible to them. And this is just the same as you would see for oncology patients who have neutropenia. They are oftentimes at risk for very similar disease states as patients who have HIV. So you can kind of almost lump them in the same sort of immunocompromised sort of setting there, because you're going to see some parallels in terms of how we manage those patients as well here. So again, our main goal though is to get the HIV down the viral load undetectable, CD4 count up. That is the best thing you can do for these patients. However, other things we can do could be potentially preventing exposure to the pathogen. So if you could do things like, for instance, vaccinating the patient to prevent disease, that may be really beneficial. And we can do what we call chemoprophylaxis. So for certain disease states, once you get down to a certain threshold, you go ahead and start prophylactic treatment. We'll talk about some examples of that here. And then if they get the disease, and you go ahead and you'll have a more intensive regimen to treat that disease. And then oftentimes once they have recovered, you'll put them on a secondary prophylaxis to try to prevent any recurrence. Because you want to treat an infection and then they get it again because they didn't have any prevention there. And then once they have recovered and their CD4 count has elevated above a certain level, then you can consider stopping the prophylaxis at that point. This list is not going to be all inclusive, and again, I recommend you go out and check out the NIH website for this stuff. AIDS info or HIV info .nih.gov has all the info you could possibly want of this stuff. And again, if you are working with these patients consistently, you're going to get very familiar with these, but I just want to touch on a few of the more common things we run into. Now, one thing you can actually run into is that, again, their HIV diagnosis might be first found along with this opportunistic infection, right? Most patients don't come up with TB, so you need to look into see, like, well, why do they get TB, right? Was it because they had high-risk exposure? Was it because they're immunocompromised? What's going on here? A lot of patients don't have PJP pneumonia unless they have some kind of immunocompromisation going on here, which could be due to HIV. So one of the things you can actually see, though, is that, they're, you go ahead and start them on treatment for both conditions potentially. So like say TB or PJP pneumonia plus antiretroviral drugs, they may actually have something called the immune reconstitution syndrome, or IRIS. And this is actually leading to their disease state seems to worsen. They seem to get sicker, but it's actually because their immune system is starting to come back online, starting to inhibit that virus. And now they actually are able to fight and mount a response to that infection there. So it's actually a good thing, even though they may feel worse when they're experiencing it. So kind of a unique kind of thing there. But just be aware, if you're treating both, what are the drug interactions you have to look out for? Compliance with all these new meds at the same time can be really tough. So again, making sure they have good support, that way they can be successful. PJP pneumonia, or previously pneumocystic carinii pneumonia, or PCP is kind of the old way we used to say it, but PJP is the newer nomenclature. This is the most common life-threatening OI in AIDS patients, and again, if you've ever seen someone with PJP pneumonia, they're some of the sickest pneumonia patients you've ever seen. It's just awful, very difficult to manage there. And the reason why it is because it's very difficult to treat. It's a fungus with these like protozoal sort of characteristics. You can't just put them on normal antibiotics and expect it to work just like you would for, something like, strep pneumo or something. And again, a lot of people who are exposed to it, they have a compromised immune system. That's why this infection is able to take hold. And so, and it's very insidious. It can take course over weeks. So by the time you finally find it, maybe you're kind of on behind the eight ball a little bit in terms of trying to get that patient recovered. So, what do we do for these patients if they develop a CD4 count below 200? That's where we're going to put them on primary prophylaxis. So basically, once they drop down below 200, we will put them on Bactrim. So sulfamethoxazole and trimethoprim will typically do a thrice weekly sort of regimen. We'll get it 3 times a week, and that way that prevents them from getting it in the first place, hopefully. If they develop the disease itself, so you do the culture and you find it, then they're going to require pretty intensive treatment. We don't like to use IV Bactrim. The only time you really see that is for this case in particular, and this is going to be treated for 21 days. So notice the treatment time is pretty long compared to like 7 to 10 days for pneumonia, maybe 14 days on the outside for 3 weeks, because they just don't have a good immune system to fight this stuff off. If they have the disease, you treat them for that 21 days and they recover, then you put them back on the Bactrim thrice weekly, a secondary prophylaxis there. Once their CD4 counts above 200, though, then you can consider stopping it because they're at less risk for developing in the first place. Thrush is another pretty common thing you may see here. If you see a patient who has thrush, there's not a lot of reasons for that other than immunocompromisation, or maybe like they have an inhaled corticosteroid. So we need to be looking at that. The risk for that is not that the thrush is so big of a problem, it's the secondary invasive fungal infections we're really worried about at that point. So if they just have oropharyngeal candidiasis, using something like nystatin is good because it doesn't get systemically absorbed. You need to swish and spit or swish and swallow 4 times a day. That's fine for that from that standpoint. Otherwise, if it's more esophageal, If it's more involved, that's where you worry about systemic infection. That's where we're going to use fluconazole, IV or PO, 7 to 21 days or so. Again, I'm not going to get specific on the duration. I just want to try to impress upon you the reasons why we treat for so long. And again, I've seen some very sick patients develop these fungal infections, and they just are not as treatable as something like a bacteria, just because they're slower growing and they develop resistance. So not great. So that's why I use something more systemic if we do see that it's esophageal. For this one, there's no primary prophylaxis, just something you're going to be monitoring for as the patients come in. And you just look in the back of the throat to see if you find these little plaques there or anything. There's lots of other opportunistic infections out there, which I'm not going to get into specific details on. Again, if you're curious, you can look it up, or if you see your patients develop these, again, look up specific treatments. It's just outside of the scope of our course here in order to get you kind of familiarized with some of the bigger concepts here with these disease states. So. Other complications of HIV is the fact these patients are living for a lot longer. If you notice back in the 80s, if you looked at the life expectancy for someone with HIV, it was pretty abysmal. Nowadays, these patients are now dying from a lot of other diseases like cardiovascular disease and diabetes and renal failure and things like that. It's more of a chronic condition than it is a terminal condition, which is fantastic nowadays. But we need to help manage these other conditions as well. So, for instance, they can develop things like HIV nephropathy. You can see renal disease associated with this, and there's certainly a risk for other cancers, so things like Hodgkin's lymphoma, hepatocarcinoma. So, really big thing here is that whenever you're treating these other conditions, so for instance, they have like a history of heart attack and HIV, you have to be looking for things like CYP3A4 interactions and whatnot to make sure that you're not going to be causing toxicities or inhibiting your other medications from working quite as well. So again, always double check your drug interactions anytime you're adding on something new. Okay. And then to wrap this section up, I'm going to talk about sexually transmitted infections real quick. So first off, we're going to have gonorrhea, and then it's common bedfellow, so to speak, chlamydia we're going to be talking about here. One of the things you're going to see with STI treatment is you want things that are kind of one and done, right? So if you can get, because compliance is always going to be an issue, and you worry about spread to other partners. So if you can do something where I can just give you a single shot in the office or in the ER, I'm done. I don't have to worry about treating you any further because I know that's going to be effective. That's becoming to be a bit more of a challenge as time has gone on, as resistance has developed. But so we'll talk about some of those cases there. So first off with gonorrhea, again, a big reason why these diseases just don't go away is because a lot of patients are asymptomatic. For a lot of these, males tend to be more asymptomatic than females, which is unfortunate because they're more likely to spread it to others. And women typically get short shrift here because, again, they can have secondary complications of things like infertility, ectopic pregnancies. They're more likely to see more systemic complications, so not great. And what's interesting too is there are also some combinations where like HIV spreads more easily for patients who have gonorrhea, right? So again, misery loves company, so to speak, and so you can see these things spreading much more quickly when you have these concomitant issues. So again, where do you go for recommendations? The CDC is always going to be first stop for up-to-date recommendations on treatment of STIs. For gonorrhea specifically, we just use a single IM dose of ceftriaxone or Rocephin. It's a really low dose, relatively speaking, for an adult, but 250 milligrams, that has been shown to retain efficacy. We don't see a lot of resistance, and that's fantastic because you can just do a one-time shot and then you're good to go. Now, there's a lot of chlamydial co-infection that occurs here, so it's recommended you just treat both at the same time. Okay. Again, one-time dosings for things is really preferred, but we're starting to see a lot of macrolide resistance to chlamydia. So azithromycin used to be kind of the go-to, just 1 gram PO once, and then you're good to go. But because we're starting to see resistance to that, now the CDC actually recommends doing a 7-day course of doxycycline PO BID for 7 days. The challenge with that is because instead of just giving them a 1 gram dose of azithromycin in the ER, along with a shot of Rocephin, now they have to take a script, go find somewhere to fill it. Hopefully they can find somewhere to fill it for free. Maybe they can't. Maybe they have to pay for it. And they have to be compliant with it. They're taking twice a day for 7 days. Compliance is going to be a huge issue here because if they stop taking it early, then they're more likely to see resistance. They can spread to other people. So it's a big challenge we're going to be seeing there. But in terms of the gonorrhea treatment, if they are truly cephalosporin allergic, which again is not super common, but they truly could not receive a cephalosporin, we don't have a lot of good alternatives, maybe like IM gentamicin or gemifloxacin, which is fluoroquinolone. Who knows? If you did have an infant that was born and they develop gonorrheal eye infection, actually topical erythromycin is preferred there. So that's one thing to note. That special patient population. And then looking at chlamydia more specifically, again, you see a lot of asymptomatic cases here, which is again why you just go ahead and treat. If you have some with gonorrhea, just go ahead and treat the chlamydia as well. Again, if you cannot use the tetracycline, then fluoroquinolones can be used as secondary agents. Just be really careful though, depending on pregnancy. You may want to stick more with the azithromycin, tends to have a better safety profile for those patients there. This should actually be topical. Apologize. And then if you had a child picked up chlamydial ophthalmia due to during birth, then topical erythromycin can also be used as well. So it's kind of nice that they get kind of dual treatment there regardless. Next we have syphilis, which is a treponema pallidum, which is a spirochete. And this is, again, very highly contagious. You see this a lot in the men who have sex with men population. And again, this is something that we can lead to more chronic systemic disease that can be really fatal. You can see things like neurosyphilis that can occur here. Fortunately, though, treatment is relatively straightforward. It's just penicillin. Like regular old penicillin is going to work great for this. We still found that it does not have a lot of resistance to it. However, the T. pallidum does grow quite slowly, so we're going to find that it's difficult to find a one-and-done sort of solution here. So what we can see is by giving benzathine penicillin G, or the bicillins, that one that comes in that kind of milky sort of lipid base, that's an IM shot. We can just use one dose therapy for that. So that's preferred. It's a one-and-done sort of solution there. Otherwise, it may require treatment for up to 2 to 4 weeks. So again, you can already see how compliance is going to be an issue with that. Doxy, tetracycline is going to be fine for those cases there. And then for more systemic, more of sort of severe disease, we can actually end up using things like continuous IV infusions of penicillin G IV. So you may see that occasionally a couple in the ICU, for instance. In terms of herpes, certainly know we have HSV1 and 2. Typically think HSV1 causing more oropharyngeal disease, but it's not always the case. It can switch around depending on what the situation is. And this is another case where there's a high percentage of asymptomatic infection, so you don't know who's spreading it to who. And even if you don't have any apparent lesions, you can still be shedding the virus. So trying to identify individuals and helping with education is really important, helping spread or preventing the spread. So typically our goals for treatment for these patients here are try to relieve their symptoms, and if we can shorten the course, that's great, and prevent any sort of like recurrent disease, and then prevent disease transmission if at all possible. In terms of treating their actual pain and discomfort, we can do things like saline baths, like sitz baths. You can do things like antipyretics, antipyretics. Just be careful because some of these can be like really like itchy and uncomfortable. So if they're trying to scratch a lot, that can lead to secondary bacterial infections. So again, make sure you keep the area clean and try not to scratch it too much. So antipyretics can come into play there. Now, in terms of treatment, we're going to see the CDC recommends for the first time treatment either using something like acyclovir or valacyclovir, which are most common. Sometimes you can use famciclovir. Just remember, valacyclovir is a more bioavailable oral version of acyclovir. It's prodrug, so that's why it has better bioavailability. And typically we'll do the 7 to 10 days to prevent shedding of the virus any further, to decrease the duration of symptoms and all of that. The name of the game here too is you want to start treatment as early as possible because you're going to find it is more effective. And basically every patient is going to get treated right off the bat here. Topical is not going to work quite so well, so systemic is going to be required. If you have those that are immunocompromised, or if they have like really severe disease, if they require hospitalization for things like herpes encephalitis or something like that, then we're going to require IV acyclovir. This tends to be more toxic. You're going to see things like bone marrow suppression, CNS toxicity, renal toxicity. Just be aware that it's much more likely to cause a lot of those complications when you're using IV than you would see with it orally. But certainly if they're taking acyclovir or any of these drugs orally, make sure they're getting well hydrated, because you can see a lot of renal damage done if these drugs like to crystallize out if they're dehydrated. So then it comes into, you can suppress the virus, but you're not getting rid of it. So the question is, well, do you do just like episodic therapy when they have recurrence, or do you do kind of chronic suppressive therapy? If they have kind of frequent recurrences, then chronic suppressive therapy, where you take it every single day, is more recommended. It also helps to reduce the asymptomatic viral shedding. However, does this really impact the spread to your partners? Who knows, because it's hard to tell. Do they even have it in the first place? Because so many people are asymptomatic. On the other hand, in terms of episodic therapy, this is where it's really critical. You want them to use it within 24 hours when the lesions appear. Most of the time, patients are going to have prodromal symptoms, though, so they will have, an as-needed script that says when to take this. Usually, as soon as they start to have symptoms, just go ahead and start taking it. These are better for patients who have maybe like more prolonged recurrences or severe symptoms. They may benefit from that. There's still no consensus on whether or not to one is clearly superior than the other. I'd probably err on the side of like chronic suppressive therapy just to prevent spread to other people, but it's going to be dependent on the patient there. And then we have trichomoniasis here, which is another protozoa. We're going to see here that this is another case where we see this much more often in women because men have a high spontaneous cure rate on their own, and it's also more easily transmitted from man to woman anyway, and a lot more men stay asymptomatic here. Treatment is straightforward, either metronidazole or tinidazole. Both of these are antiprotozoal drugs that can damage their DNA. 2-gram dose of either as a one-time dose is fine there. This is another interesting one where treating the partner also leads to better cure rate, because you don't want to treat the female patients complaining of symptoms, then they go back home, have sex with their partner, male partner, who gives it back to them, right? So in Florida, at least, we have laws set up to where like, even if you don't see their partner, you can still write a script for their partner for one-time dose of metronidazole, for instance, and the pharmacy can fill that even though you haven't seen them, in order to sort of curtail spread of the disease. So it's interesting. Florida law, you'll probably see that in a lot of other places as well. So that's it for this section. A little bit of a shorter day. I'm sure probably don't mind too much. But do any of you have any questions? Again, I updated the due date on your ARCS assignment, so it's going to be due on the 23rd by 6 p.m. So about 2 weeks to get that taken care of. Any questions at all? If not, you're free to go. Stay on for a minute or two, just see if anything coming up. Nothing on the sticky board. Nothing in the chat. Thank you for joining me. I appreciate it. Okay, well, I'm gonna go ahead and sign off. But you guys have a great week, and I will see you all next week. Have a good one.